Welcome to the University of Washington School of Nursing Voices of Nursing podcast, where we dive deep into the diverse and inspiring stories from the heart of healthcare. We'll amplify the voices of top-notch nurse leaders, researchers, and scholars sharing their experiences, challenges, triumphs, and the profound impact they make on patients, families, and communities. This is Voices of Nursing. Well, welcome to the School of Nursing podcast. I'm here today with Dr. McLemore, Professor and Interim Associate Dean for Equity, Diversity, and Inclusion, and the Interim Director of the Manning Price Spratland Center for Anti-Racism and Equity in Nursing, or also known as MPS Care. Dr. McLemore is a leading scholar and scientific authority in the field of anti-racist birth equity research, community-informed methods, and policy translation. Dr. McLemore's findings have garnered widespread recognition and citation, and she serves as a guiding light, empowering individuals and organizations alike to develop and implement interventions that promote equitable healthcare practices and policies. And also, Dr. McLemore is just a lot of fun to talk to. We're very glad to have her joining us today. We're going to talk a little bit about the upcoming events of Nurses Month. There's going to be a documentary called The Shift documentary out May 10th, so we'll talk a little bit about that today. And I'm also joined by Brilliance Jones, who happens to be a member of the marketing and communications team, but is also a consultant to the AFIA Center, which is a reproductive justice center based out of Texas. Brilliance. Did I get that right?
Yes, you did.
Okay.
Hi.
Very good. Hello. So kicking us off today, Monica, do you want to tell us a little bit about your journey to today? So why in particular nursing research, and what were some key inspiration points to get you to where you are right now?
Got it. Well, first of all, thank you. I am so excited to be here. And, I have to shout out Marcia Jones and the AFIA Center. They are research collaborators of mine, and I've known her for years. And so it's super excited to be able to have Brilliance here with us on our team as well to make that connection. So, I have been a licensed registered nurse since 1993. And I decided when I was 8 years old that I wanted to be a member of the health professions, even though nobody in my family was in the health professions. And part of it had to do with the fact that I was a preemie in 1969. I was a very sick child. And I spent more time with nurses in my formative years than I did my family and my parents. And I remember thinking to myself, if I survive all of this mess, and, I had back braces and leg braces, and, I wear glasses and all these sort of physical things. If I survive all of this and I wore all of these things and had all of these interventions, and then I had eczema and psoriasis, before I was 12, I said to myself, I want to be able to do what other people have done for me, which is allow me to be a child, to be human, to be scared, curious, and to help my body to heal. And so that's why I only, applied to, schools of nursing when I went from high school to college. I didn't apply for any of the majors. And this was back in the day when you could still declare nursing directly from, as your discipline of study. You could apply right to, I have 3 degrees from public institutions. I believe in public education. That's why I'm a professor at one. But I applied directly to nursing programs because that's what I knew I wanted to do with my life. When I finished my BSN, which was my favorite degree, I have to say to people,
Nice.
People be like, Monica, and let me dispel another rumor, because people think I function at the advanced practice level, and I do not. Okay, I am not credentialed or certified as an advanced practice clinician. I don't work as a midwife. A lot of people think that I do. My master's is in public health, and that was intentional. And I want to say this to the listeners, that there is nothing wrong with baccalaureate nursing education. I work as a baccalaureate nurse. So to me, I know our discipline in our field spend a lot of time on people in advanced practice, but the truth of the matter is, I love my BSN, and that was my favorite degree. I went to a liberal arts school in Trenton, New Jersey, and, it has shaped me as to who I am. I will remind the listeners, since I was a preemie in 69, let's be very clear, this was a year after the Civil Rights Act was passed. This was also after we had to desegregate hospitals because, the American Medical Association didn't want to do that. But the federal levelers and the federal government had to pull their levers to say that you would not get Medicare and or Medicaid funding if you did not desegregate, right? So it's fascinating that I was at, Children's Hospital in Philly and had to deal with all these sort of ailments a year after Black people were actually allowed to access those services, right? So, but I thought for a while I wanted to be a midwife or a family nurse practitioner. In fact, I applied to the program at Penn and got in right after I finished my BSN, and I didn't go because I wasn't really ready. But then I shadowed some advanced practice clinicians, and I realized this is not the life I want. This is not going to make the systemic change. Being one-on-one, in the traditional model of how we provide healthcare in the United States, that's like a one-on-one, like very small, narrow view of how to try and create change. And I thought to myself, there's a reason that this model doesn't work to be able to make systemic change. So after I did that, I was like, okay, but you still have to advance your education. So I took an epidemiology class. And on a whim, I was like, okay, I like population health. I like to think about groups of people. I fell in love with public health. So my master's degree is in public health, and I function as a public health nurse. And then, I went straight from my MPH program to PhD program. And it's because I understood one very simple thing, and that is master's prepared people who want to do research are consistently going to, unfortunately, be relegated to working on the projects of people who have PhDs, MDs, or other terminal degrees. Because their skill set is more operational. Their skill set is more about program planning, program evaluation. But to really come up with the research questions, the methods, the ways in which we understand the complexity of the human experience through science, you really have to have that advanced training. So I applied to PhD programs in the middle of my MPH program, and I graduated in May of 2002 and started the PhD program in September of 2002. I do not advise that people do this. However, to do it all again, I would do it exactly the same way. Because I was already in school mode. I was already working with a really great team. We were mapping the human genome. And I got to marry my love of nursing and community health education, which is the concentration of my master's in public health. And then I got to become a laboratory scientist. So for me, I wouldn't do it over again differently, but I don't tell people to go straight through. I try to get people to hold on to their humanity and have a break and rest your mind and see your family and read a book that's not about school and be like a real human. But I did it that way. It worked for me. I wanted to finish the PhD before I was 40, which I was able to do because that was a personal goal of mine. And that set me off on a research career where I've really just been trying to understand a very simple principle, which is reproduction, whether it's propagation of the human species or like reproduction of ideas or opportunities. It is a process that shapes human experience because it forces us to engage with other people. And Homo sapiens / humans are like communal species. So for me, I like to understand that messiness, that complexity. Why do we choose to engage with each other and how? And why does that matter? And what implications does that have for both the past and the future? Like, that's how I think about it. So for me, besides, I'm also a really geeky Gen X kind of person. So I really love the meat of science. I love data analysis, whether it's qualitatively reading through interviews and transcripts or like running statistical packages. I really love data analysis. That really helps me to enjoy the geeky part of my life. So that's why. I mean, ultimately, we can't have effective interventions to support human health if we don't have good evidence behind it. And more bluntly, the way that I think about this is we can't have good policy if it's not supported by good evidence. And, say what you want about misinformation and disinformation and all the ridiculousness of our current environment. But the truth of the matter is there are some basic tenets that I think we subscribe to that are really important to outline. And one of those is the scientific method is one important tool, not the only one, for us to be able to understand relationships, environment, interventions, and health and wellness across time. So that's how I think about it.
That is amazing. I don't know if I want to go get my PhD tomorrow. I don't know exactly. Right now, I'm just listening, and I'm like, okay, so I got to call somebody at School of Public Health tomorrow because I just listening to you, I literally, a younger version of me is like, I wish I would have met you when I was a kid because science sounds so cool coming from you. Science sounds like exactly and I was one of those kids that was like, I would never do science. I'm a writer, I'm a reader, I'm a creative. And now I'm like, I could have been using that whole other side of my brain to do amazing work.
The truth of the matter is this, right? I mean, my job as a professor is to activate students. Right? My job is I'm not the first Dr. McLemore in my family. That's my sister, and she's a pharmaceutical chemist. You talk about super geeky person, but she also makes much of the jewelry that I wear because she is an incredible jewelry artist.
That's so awesome.
The false dichotomy that art and science are separate things in the world is something that nursing has always rejected, right? We've always said nursing is an art, nursing is a science. Same with public health. I think fundamentally that, and you have no idea how many times I hear that from people. They're like, God, I wish I had met you before. And I'm like, you know what? It's one of the reasons why I'm a public scholar. So we're sitting here recording this in the midst of Black History Month. And one of the things I always try to explain to people, there's more than one way to be a human. There's more than one way to be a scientist. There's more than one way to be a Black person. And yet, the ways in which those experiences get represented, in my opinion, is really flat. Mm-hmm. And I don't really like that. So I just reject that. That's the other thing. I'm trying to get people to be more comfortable in rejecting false dichotomies and paradigms that are fake. Because, I mean, if you think about it, all we really want as a species is a dignified life and a dignified death, right? I say this all the time because immortality is not an option for our species. So we all get born and then we all gonna die. That's a thing. I need people to accept that. But it's really what you do that matters, and in my mind, getting people excited about science, about health, about well-being, about nursing, about public health, about making the world different, reminding people that every decision we make in the present changes the future. So we need to be mindful about the frameworks we use to make decisions. That's my job. That's the gift that I have of 3 different public institutions allowing for me to learn, grow, and teach. So that's how I think about it. And, as a clinical nurse, one of the things that I've learned, and right now, it's so unfortunate because the only clinical work that I'm doing is flu and COVID vaccines because of the, busyness of professorial life. I wish we could have a health system that would allow for all members of the health professions, not just to prioritize our physician colleagues, but to really be able to create opportunities where we can be in the clinical environment, we can be in the research environment, we can be in the classroom environment, and not feel like one has to suffer because the others are so chaotic or inhumane. So for me, even working clinically, it was always important that I curated space as a nurse, and I try to get early career people to understand that this will come. When you execute basic nursing, it's like watching an Olympic gymnast. right? You don't see all the injuries. You don't see all the hurt. You don't see what you see is a flawless performance. You miss all that behind the scenes stuff. Why? Because excellent nursing care is shared work. And it's a team. So it's almost seamless and invisible when it actually is operationalized in the way it was theorized and intended to function. So for me, and nursing is the only thing I've ever done for pay as an adult. Let's be clear. I used to work at the Limited, right, in the mall. Gen X, let's go, y'all. And then I worked as a home health aide while I was a nursing student. But as an adult, I have never done I was licensed as a nurse at 20, right? I mean, because this was back in the day where they didn't make you wait until you was 5 to go to kindergarten. And my birthday's on New Year's Eve, so I went to kindergarten at 4. And so I got licensed as a nurse at 20. I could give out narcotics before I could actually vote or drink alcohol. So, it frames everything that I think about, everything that I do. And it has shaped my life in a lot of very intense ways. I mean, we were talking about AFIA. AFIA, for the listeners who don't know, it is a reproductive justice organization that serves HIV-positive individuals, and they do amazing public health and direct service work in the community. And, I trained in 1988, right, the height of HIV, when our federal government wouldn't even use the words. That shaped me. We lost a generation of people. I mean, even now when I'm watching the band plays on and Angels in America and all the sort of literature documenting that time, I'm getting teared up right now. We let a generation of people die. And so one of the reasons I came out early on, writing pieces around COVID, making sure that we weren't going to continue to see, health disparities and more widening of inequities, because I have grown up as a nurse dealing with every infectious disease. I mean, H1N1, Zika, SARS, Ebola. I mean, when you think about all HIV, right? Now COVID, when you think about all the different ways in which our species has had to interact with the biological world, it is a moral statement to determine how we allocate clinical and public health resources to save each other. I need more people to talk about stuff like that, right? Because I'm just about done with this idea that we can't change our clinical and public health services infrastructure. That is a lie that people are telling us to continue to try and control the decisions we make in the now to change the future. Mm-hmm. So I feel very strongly, and so you ain't asked me this, but I'm going to say this anyway because y'all know I do what I want. The reason that advocacy is such an essential component and competency of nursing education, we unfortunately only operationalize that around patients and the people we serve. Mm-hmm. But actually, it's also around us as a discipline and a profession. And quite frankly, to remind clinical health services provision, and I make that distinction from public health because those two things are different. Mm-hmm. And unfortunately, I believe a lot of our physician colleagues have co-opted public health and imposed upon it practices and policies and procedures from clinical health services provision that neuters the strength of public health. Yeah. So, and that's why everybody want to work with community-based organizations, right? Or they see that as a potential intervention or improved partnerships to improve health. It's because we've subsumed the power of public health in clinical health services provision as opposed to appropriately funding public health and a robust social safety net. Let's get on that. Okay.
I'm loving every direction.
Let's get on that. We're going to get on that.
This is so good.
Because that's a whole other situation. Let's get on that. The reason that countries in the world have better health outcomes, and I work in reproductive health rights and justice, right? And I will remind the listeners, the reason that reproductive health rights and justice is a barometer of the health and wellness of a country is because pregnancy is not a disease. It's a normal physiological condition that needs to be witnessed. It is an indicator of us and the investments that we use, not only to ensure our existence in the future, but also how we treat people who need health services provision or services that happen under the clinical umbrella that aren't sick, right? And if we can't keep them alive, what makes us think we can keep deathly ill people alive? Okay, but that's a whole other conversation, okay? So when we think about Norway and Finland and Sweden and other countries that have better health outcomes for their populations than the white people in the United States, let me say that again, right? People who live in Norway and Finland and Sweden and the Netherlands and all these other places, their white people have better health outcomes than the white people that live in the United States, let alone the Black, Indigenous, and other populations. It's not because, of some white supremacist view that Europeans somehow have better life expectancy. They have a robust social safety net that allows for their constituencies and citizens to not have to have premature death because of negative social determinants of health. So let me explain what I mean by that. When you have paid family leave, right, when you have generous child care benefits for all co-parents involved and other family members in the supplementation of that family unit, when you have excellent transportation systems, when you have basic minimum income for your citizens, when you have, housing, when you have food available for folks, we should not be surprised that you get superior health outcomes. So to me, we will never resolve the negative social determinants of health in clinical care. That will never happen. So to try to do so, in my opinion, and this makes me very unpopular around a whole lot of people, like the food justice folks. They get really mad when I start talking about food as medicine. I said, do we have to medicalize everything in order for us to be able to just say there's some public good that we want to be able to provide for our citizens?
Right.
Seriously?
Got to be a medicine.
Can't just be food. Food on its own.
No, not enough.
Like, when we going to get back to public good?
Yes.
Right? I say this so just when I upset my military friends too. And to be very clear, I'm the daughter of a Marine, Semper Fi, let's go. But we don't force the military to provide us reports at the end of 3 years or a budget cycle for the wars and the conflict they prevented. We don't force them to do that. So why are we asking the scientific enterprise to change the world, and then I got to write a report in 3 years to tell you about something I prevented that I can't measure? I'm done. We need to start talking about the public good of science. We need to talk about the public good of public health and fund it as such. So, but we have the commercialization and everybody wants, the corporatization of stuff. It drives me up a tree. And I can't state this enough, that nurses need to push back, and so do public health people, around this corporatization of all things, or the commodification of all things. Nursing care should not be a budget line item. Right? Because if you could go to your doctor's office, you would. People come into hospitals and healthcare institutions because they need nursing care. So it should be funded as an essential component to keep the doors open.
Correct.
Right? So the older I get and the more I think about how I wield power in the world and the leadership that I have as a professor, as a consultant, as a clinical expert, I say these things in all the rooms that I'm in, and sometimes it gets me in trouble. And, I can, cite off a ton of statistics or a whole lot of data. But the truth of the matter is, I think as we mature in nursing science and as we mature in public health science, speaking directly to the public, and having media competencies, being able to translate that geeky science to the people who originally funded it, if you have federal funding, is that should be an expectation of knowledge dissemination, or what we'd like to call diffusion of innovation, right? Why can't we get translation of our scientific findings? Well, if you firewall journal that the public can't access, if you're not pulling out your figures and doing a Facebook thread or Instagram Live or some use of technology that the public is using, then we can't be confused when misinformation and disinformation, which is free, by the way, runs rampant.
Such a great point.
And why don't people trust institutions?
Let's get on the institution. Let's get on the institution.
Why don't they trust us?
Because I'm about to give y'all a painful and an inconvenient truth about institutions. Everybody was really shocked. So when we came out of lockdown, everybody was really shocked when I left the University of California, San Francisco, and came to the University of Washington, because people know I have a love-hate relationship with academia just to start with, because Black women are not safe in academia. Let's be clear, and I'm not dying at work. I said this several times. I'm keep saying this. And I'm not being ousted by donors either.
Right.
However, I will say this. The strength of our institutions is only as strong as the people who engage with them. And this makes early career faculty, especially my mentees, very grumpy. But if we're not holding our professional organizations accountable then why are we members?
Right.
Right? Like right now, if you're not submitting an abstract to have a simulation at a professional conference around how to disrupt anti-racism in real time in the classroom, then you might need to take a seat and shut up in your critique. Because in my mind, critique without action is just complaining. And I don't really like that. Right? So for me, our institutions are only as strong as the willingness of the people who need to participate in them, whether you're talking about a democracy or you're talking about a department at a university. So one thing that I'm currently working on as a member of several search committees, because we have some faculty positions, come work with us, is changing our job description. Our current job, many of our job descriptions read like legal documents or corporate documents, right? They don't read like, hey, we have a vibrant research environment. You want to come hang out with us. So I have been deeply editing many of our job descriptions to talk about our beautiful campus. We have, centers of excellence that have been nationally identified for our expertise in our research. We have a killer student body. And if you didn't know this, our Husky football team got it going on. Go Championships.
Yeah.
So, but our ads read like a corporate commercial. Nobody wants to go work there.
Yes.
Right? So as we rethink the role of institutions in a democratic society, and when you think about the role of academic schools of knowledge, we have an essential and historical role that is to educate the populace, right? Not to train people how to get a job. That is the incredible work of our apprenticeship programs and all. Liberal arts education, which I deeply believe in, is to prepare citizens to be citizens, to know how to critically think, to know how to appraise a situation, to have ideas come out of their mind and not their phone, right? I got in trouble because I did an Instagram Live and I was going on and on about how one of the reasons I'm not a fan of augmented or artificial intelligence, and don't get me wrong, I'm an early adopter to technology, but here's the rub I have around AI. I don't need to imitate somebody else, and I don't need anybody imitating me. And the truth of the matter is, I get that these are good tools but all tools need rules, in my opinion. And so, if you are a person who struggles with language and you need a draft, great, do you. But you got to edit it.
Right.
Right? I mean, so I also don't like imitation. I find that to be just like, it makes my teeth itch. So I also don't like leftovers. So I am one of these people that I also try to be proven wrong, and I try to fail as spectacularly as I succeed. So I am hoping at some point I am wrong about the, AI train. But the truth of the matter is, at least for now, because we're not in the matrix yet, you still need humans to generate that content. And I am not prepared to cede the creativity, the curiosity, the love of words and literature and ideas and thoughts to the machinery we create.
It's limited, yeah.
That's how I think about that.
Very good point.
And I know you're deeply connected to the work of the Algorithmic Justice League.
Oh, yeah.
And one of the things that Joy Buolamwini said in her book, Unmasking AI, was that these problems, right, like the problems of climate justice, that's not a technical problem. AI can't solve it because it's not a technical problem.
Right.
Like health justice, that's not
these are human interactions.
Human problems.
And I get very grumpy. This is the other thing. There's nothing wrong with being human. Right? Don't get me wrong. I can get into some, cyberkinetics, and we can geek out and do that whole thing. But the truth of the matter is, and this is why I keep doubling down around being a member of the caring and the health professions, right? The care economy is so devalued. It is such a tool of patriarchy to keep coming back to this notion that there is something wrong with caring for each other. I will never cede that ground. Never. As technologically savvy as I am, as early adopter of technology as I am, I will never cede the ground that caring for each other is one of the biggest gifts, one of the most existential experiences that humans can have. So I'm going to be the pain in the ass that is going to continue to drive that point home, or to continue to try and trouble these discussions, because we have to create a nuanced synergy where people who need tools and technology can do them safely. People who have been over-marketed to and are experiencing mental health crises and crises of social isolation and a whole variety of other things because they don't know how to engage with other human beings. Let's work on that too. Mm-hmm. Right? For the people whose lives have been improved by technology, disabled people who use it all the time, let's give them what they need. But what we really should always stop and ask ourselves is this evil? And if so, then how do we stop having it be evil? These need to be fundamental questions, right? Who are we excluding? Or is this inclusive? And if not, why not?
That concludes part 1 of our captivating conversation with Dr. Monica McLemore, diving into key moments that inspired her lifelong career in nursing research. Join us next time for part 2, where we dive deeper into critical conversations around reproductive health, rights, and justice. Stay tuned, and thanks for listening.